Everyone seems to be settling down. Allow for me to introduce a very great speaker who is a practicing clinician, researcher, certified de-addiction therapist, wellness coach, author, speaker, and lecturer who has lived and worked in the United States for more than 30 years. He has been involved in the fields of wellness and complementary medicine for over 20 years. Living in New York has provided him the opportunity to learn many cutting-edge therapies straight from the masters and pioneers who have made these breakthroughs. He has also developed several therapies based on his own research and has taught these unique modalities to doctors, nutritionists, fitness trainers, and performance coaches, both in India and abroad, through his lectures and writing. He has worked with people from many parts of the world in his wellness programs and has traveled extensively. In his role as a practitioner of integrated medicine, he has helped many cancer patients, heart attack victims, and diabetics. And he himself is a doctor to some doctors. He is published author, having written many articles on wellness and alternative medicine in several magazines, newspapers, and newsletters. He has been frequently sought out for lectures and interviews, and precisely the reason that he is here this afternoon to share with us his expertise. Please, a warm welcome to Dr. Suresh Shottam.
Thank you. Can you hear me in the back there? Thank you. So I think most of us are half asleep, right, after lunch. So let's see if I can keep you awake. There's Sunita, smiling away. Okay, so what I'd like to do is talk a little bit about our conventional understanding of heart attacks and challenge the hypothesis, and then present an alternative view. The current hypothesis leaves a lot of unanswered questions and a lot of confusion, and the alternative view answers many of those unanswered questions. So I'm going to talk about it in two halves, the first half being challenging the current prevailing theory, and the second half presenting an alternative viewpoint. So until recently, it was thought that most heart attacks were caused by progressive blockage created by plaque buildup in the major arteries leading to the heart. The plaque was thought to be cholesterol buildup in the arterial lumen, which eventually cut off blood supply to a certain area of the heart, resulting in oxygen deficiency in that area of the heart, at first causing pain, angina, and then progressing to ischemia or heart attack. The simple solution was to unblock the stenosis with either angioplasty or stents, and if that was not possible for some reason, to bypass the area with a coronary bypass graft or a cabbage surgery. Okay, a simple problem with a simple solution. That has been accepted as science, but when you look at it carefully, it's more belief than science. The thrombogenic theory that advocates myocardial infarction is a result of coronary thrombosis, was introduced by Dr. Herrick back in 1912. And it became accepted worldwide in the medical culture in spite of important clinical and pathological cardiac image studies showing discrepancies in the theory. So, how do we treat, assuming that the theory is correct, that the one or more of the coronary arteries are blocked, So one of the ways is to treat with anticoagulants. So initial efforts to apply anticoagulant therapy early in the treatment of acute infarct and then long-term did not serve to further the cause of coronary thrombosis. Trials of anticoagulants for acute heart attacks were not very encouraging. Any improvement in survival statistics were more likely due to prevention of the thromboembolic complications, that is, like pulmonary embolism, for example, rather than in the treatment of the offending coronary artery thrombus itself. Here's a story that I'd like to share with you. So let's see, a 45-year-old man with unstable angina developed persistent ECG changes of myocardial ischemia while they were conducting the angiogram. So the occlusion of the LAD was documented 20 minutes after these changes occurred. The intracoronary nitrate calcium antagonist urokinase removal by PTCA of the atherosclerotic obstructions and emergency bypass surgery failed to restore myocardial perfusion. So the heart was not getting any blood in spite of all the procedures. Only short periods of reflow were obtained with urokinase and PTCA. The repeated coronary injections demonstrated a progressive disappearance in the angiogram of the LAD, starting from the distal portion and progressing backwards through the whole vessel, origin of the vessel. The patient developed transmural anterolateral myocardial infarction and 12 months later underwent cardiac transplantation for untractable failure. His heart, which was removed, was examined and the infarct was confirmed. Analysis of this case suggests that coronary occlusion in acute myocardial infarction happens after the event rather than the blocks actually happen after the event rather than be the cause of the coronary block. It's very important to keep this in mind because I'll show you plenty of evidence to show that the thrombosis occurs after the event and is not the cause of the event. See, there's a problem with the conventional view. See, in Alabama, angiograms were done on men presenting with chest pain. Okay, patients with a single artery block were required to have no treatment. And the researchers predicted in their notes which part of the heart would be affected from that blocked artery. Okay, and they sent the men away with no treatment, and they all waited, and the researchers predicted which part of the heart would have the attack if there was an attack in future. And they all predicted that the part of the heart that would be affected if there was a heart attack would be the one that was leading, the blocked artery was leading to. And to their surprise, they found that less than 10% of the heart attacks, the heart muscle in that part of the heart was affected. In other words, the blocked artery did not show an impact on the heart muscle in more than 10% of the cases. So what happened to the other 90%, where the infarct happened elsewhere, away from the blocked artery? Okay, so in another study conducted in 2003 in Mayo Clinic, showed that bypass surgery relieves symptoms, chest pain, but bypass surgery does not prevent further heart attacks, and only high-risk patients, those whose lives are in acute danger, benefit from bypass surgery with regard to a better chance of survival. So what happened was, because of all the mounting evidence against the thrombogenic theory, they moved away, the cardiology community started moving away from the stable plaque theory to the soft plaque theory. So they abandoned the stable plaque model because of the reasons that I just outlined, and they moved to the soft plaque. But the new model also comes with plenty of problems. So what is the new model? The unstable plaque theory. This type of plaque doesn't actually create a large blockage. It's a soft, foamy substance that under certain situations rapidly evolves and abruptly closes off the involved artery, creating a downstream oxygen deficit, followed by angina, then ischemia. These soft plaques are thought to be a combination of inflammatory buildup and LDL. And that's why statins were developed to target these two areas, inflammation and low-density lipoproteins. Therefore, the thinking goes, because this type of plaque can build up in anyone's arteries at any time, everyone should be on statin heart therapy. Angiogram studies have been presented to prove the evolution of these unstable plaques as proof that they are the true cause of the heart attacks. This doesn't hold up. The theory of unstable plaque doesn't hold up under investigation. See, clinical studies consistently demonstrate that plaques rupture without any clinical symptoms. It happens all the time. When a plaque ruptures, the general theory is that the ruptured plaque causes a myocardial infarct, but it doesn't all the time. So when a plaque ruptures and doesn't cause an event, how effective is it in causing heart disease is a question that you have to keep in mind. More doubt about the coronary artery theory. When careful measurements are done assessing the partial oxygen of the myocardial cells during an MI, to the huge surprise of many, there is no oxygen deficit ever shown in evolving. In other words, the PO2 remains the same. It doesn't diminish as they tell us it does. The coronary artery theory is based on lowering of the PO2 in myocardial cells. And if the PO2 doesn't change, then what exactly happens during a heart attack? Here's an interesting study. The heart catheter protocol, the picture that the patient gets after an angiogram shows the coronary arteries as standalone units, right? End arteries, we are told they are. No attention is paid to the collaterals at all. So if you look at it, at the arteries in isolation, a block of 90% looks extremely dangerous. So most cardiologists have maintained strongly that circulation, collateral circulation, cannot compensate for this kind of a block. And therefore, intervention is absolutely necessary. Okay, so the angiogram usually convinces the patient because the blocks look so dangerous because you're looking at coronary arteries in isolation without looking at the collaterals. So without the knowledge of collaterals, the picture looks very bad. So here we are. There's a block there, looks very dangerous. There's a block there that looks very dangerous, and there's a block here that looks very dangerous. But what we fail to recognize is that blood flow is not impeded downstream and upstream. See? So the heart is always well perfused. No thought is given to how this blood got there. If the obstruction was causing ischemia, how did that blood get there? Simple question which cannot be answered by current prevailing theory. So let's offer a different viewpoint of stenosis. Here's a picture of the coronary arteries with the collaterals. Look at the intricate web. Nothing is in isolation. Nothing is in isolation. Everything is very well and with multiple connections. So, I'd like to introduce you to the work of a very fascinating person who lived a long time ago, and his beautiful breakthroughs were completely ignored by the medical community. Okay, Giorgio Baroldi. And so he created what is known as artificial blood. So let's drop that. So what he did was he created artificial blood which behaves just like real blood in every way. In other words, when it's injected in pulses, just like blood circulation happens, it congeals after a while and it sets. So what he did was he took the bodies of people who died of MIs, acute MIs. He injected the entire coronary arteries and the collaterals with this artificial blood. And then when it congealed, he dissolved the tissue in an acid bath, leaving behind the flow pattern of the blood. And in every instance, thousands of such things, experiments done, there was never an absence of perfusion to the heart because of collaterals. So, no reduction of blood supply. See here, even though there's a block, you can see it's well perfused. And here, this was the area of an old heart attack. See, there are no vessels. So, but if you can see, there's perfect circulation. There's absolutely no blocks. And still the heart attack happened. So what caused this heart attack? It was certainly not a lack of blood flow. So the development of a heart attack is not related to impeded blood flow, as is clearly shown here. So moving further into see, here's the anatomic model. So looking further, the complete blockage of the artery here did not stop the heart from being well perfused. And again, there is no stenosis here, and still the MI happened. So, here's one more to drive home the point. See, severe stenosis in the right coronary. And yet, there's blood supply here and here. The blood supply to the whole of the heart muscle is intact. Absolutely no deficit. So we are told that the risk of heart attack goes up the greater the blockages. Isn't that what we're told? In other words, a 99% block is really dangerous. But actually, it's counterintuitive, because the greater the block, the longer it's taken to form, and therefore the greater the development of collaterals. The lower the block, for example, the 30% block hasn't had enough time to develop collaterals. And strangely, because of the lack of collaterals in the 30% block, it puts the person at greater risk for an MI than a 99% block. A 30% reduction in arterial caliber is a greater risk than a 90%. And there are your studies. And it gets even more interesting. American Journal of Cardiology commented on a study showing absence of thrombosis during an acute myocardial infarct. And there was a study from Japan using intracoronary catheters to aspirate the occlusive stenosis. Okay, so it was performed during the infarct. While the heart attack was happening, they aspirated the block. Okay, and guess what they found? They found the pathological findings that intracoronary thrombus is absent in a substantial number of patients, indicating it contributes little to the pathogenesis of average. So removing it did not stop the heart attack, in other words. Further, retrieved thrombus material aspirated during a rescue percutaneous thrombectomy in 211 patients undergoing primary PCI within 6 hours of the symptom. What happened was, when they took out the thrombus, they tested it and they gauged the age of the thrombus to see if it was an old thrombus or a new one. In about 50%, they found old thrombus. In about 50%, they found new thrombus. So what does that prove? That in 50% of the cases, if the thrombus was the cause of the heart attack, how could it be old thrombus? Okay, so another mistake that's made in cardiology typically is to confuse the so-called coagulum, which is completely different from a thrombus. This red thrombus, which is a coagulum, is abnormal platelet aggregation, is confused for a thrombus very often. And the patient is treated with blood thinners, and the blood thinner will do nothing for this. So, autopsy shows coronary thrombus as a result of the heart attack, not the cause of it. So the thrombus happens because of the heart attack, it is not the cause of the heart attack. Because if it was, there would not be old thrombi. Further, radioactive fibrinogen was pushed into the blood, and guess what happened? It was incorporated into the thrombus. If the thrombus had formed before the attack, how can the fibrinogen be incorporated into it? Proving again that the thrombus happens after the event and is not the cause of the event. Okay, so we'll skip over that. So the conclusion. Oh, one more. I wanted to share the Passion trial. Anybody familiar with the Passion trial? You should look it up. It's a very important trial which was completely ignored by the medical community. It found that the thrombus aspiration, in addition to the percutaneous coronary intervention, they thought if they aspirated the thrombus, they would get better results. And they found they did not get better results. So what does that prove? That the thrombus had nothing to do with the attack. So the conclusion, before we move on, to the alternative hypothesis. Thrombus associated with myocardial infarction is a real phenomenon, but in no study has it been found to be in more than 50% of the heart attack victims. So if only 50% had thrombus after the event, why did the other half get their heart attacks? The second conclusion to draw is what caused the heart attack in the other half if the thrombus wasn't there? Right? So let's look at, so far as cardiology is concerned, the focus has been on the coronary arteries as being the place where the MI occurs, and the coronary arteries being the cause of the MIs by blocking blood supply to the heart. And we can clearly see that in spite of advanced blocks, the heart still gets its blood from multiple collaterals, and that in no case was there a condition where the heart did not get blood. Because upstream of the blocks, you saw, the angiogram showed that the arteries are full of blood. The only place that blood can come from is from collaterals. The end artery theory and the angiogram makes the situation look very dangerous, but when you factor in the collaterals, the blocks become irrelevant. So if the blocks didn't cause the MI, what did? So let's look at an alternative viewpoint which makes a lot more sense and which answers a lot of the unanswered questions and which is not filled with inconsistencies. So what is that? We have to move away from looking at the arteries and start looking at the myocardium, at the heart muscle, which is where the event actually happens. If you abandon the coronary arteries as the cause of the MI and look at the heart muscle, a whole world opens up, a whole new world opens up. And why is that important to us? Because the way you're going to treat heart disease will change radically, and the results you'll get will be far superior, and the interventions will be maybe in less than 5% of the cases. So the patient with coronary artery disease does not die of coronary artery disease, he dies of myocardial disease. In other words, the disease is in the heart muscle, not in the coronary arteries. This leads to better management of the patient, so it's important. So if we're moving our focus away from the coronary arteries to the heart muscle itself, what are we going to focus on? We're going to focus on the autonomic nervous system, right? We have two distinct nervous systems in the body, autonomic and what's the other one? Central nervous system, right? The CNS controls our conscious functions, such as muscle and nerve function. The ANS controls the function of our internal organs. So the ANS comprises of the sympathetic nervous system and the parasympathetic. This is where our focus is going to lie. Okay, it's the imbalance between the two branches, the sympathetic and the parasympathetic, that is the main cause of myocardial infarction. Okay, so it's the imbalance. So we're going to look at this in a little bit of detail so that you can understand why this, approaching it from this point of view makes a lot more sense and will make you a lot more effective in dealing with cardiac disease of all sorts. Using a heart rate monitor, which gives a real-time accurate depiction of the status of the two branches. It has been shown in studies that patients with ischemic heart disease, the parasympathetic nervous system is dysfunctional to the point of about 66%. Only 1/3 of it is working. So the worse the ischemia, the lower the PNS function. %80 of ischemic events have been shown to be preceded by a significant and drastic reduction. The PNS system goes down, and then the event happens. I will show you many studies of that. Okay. So, without the PNS going down, the interesting part is this. We're all told that stress causes heart disease. It doesn't. The body is developed over billions of years. Our evolution helps us to, just like a deer in the jungle, which is exposed every minute of its life is life or death situation. But do you think a deer enjoys its life? Yes, it does, because it is equipped to deal with the stress. So are we. So it's not stress that causes the heart attack. Study after study shows the body can take incredible amounts of stress, provided one thing happens, provided your parasympathetic nervous system is functioning properly. Parasympathetic nervous system puts the brakes on the sympathetic nervous system. When it doesn't put the brakes and this goes crazy, that's when it happens. In every case of a myocardial infarction, you will see a long time prior to the event, the PNS study keeps coming down. And then the event happens. Without the PNS coming down, there is no event, regardless of how much stress there is in the person's life. So, without the preceding decrease in parasympathetic activity, activation of the sympathetic nervous system does not lead to an MI. Stress alone does not lead to ischemia. PNS reduction plus stress leads to an MI. Both these are necessary. So, there are things that play a role in regulating the PNS, and that tells us how and why things happen. Acetylcholine, NO, and GMP are three of this thing that control the sympathetic nervous system and the parasympathetic. Okay, the decrease in parasympathetic activity. See, stress is a normal part of life. We can deal with it. The decrease in PNS is mediated by three chemical transmitters. That's your acetylcholine, NO, and GMP. Women have stronger vagal activity. That means women's PNS in general is a lot better functioning than men's, which is one reason why women are at lower risk for heart attacks than men. It has nothing to do with the coronary arteries. It has to do with the parasympathetic nervous system. Hypertension causes a decrease in vagal activity. Hypertension causes decrease in vagal activity. Smoking, diabetes, physical and emotional stress, all of these cause a decrease in PNS. So all the significant risk factors have been shown to downregulate the activity of regenerative nervous system. Here's a graphical representation so this is a healthy sympathetic nervous system, adenosine monophosphate. Okay, metabolic activity, keeps making energy. Helps you deal with stress, increased performance with adrenaline and all those things. Here, healthy parasympathetic nervous system. NO, GMP, it stores up energy and puts the brakes. When this goes out of control, this puts the brakes on it. When this mechanism fails is when the MI happens. So when the PNS is blocked, let's see what happens to heart rhythms. Every time we breathe in, what happens to our pulse? It speeds up. Every time we breathe out, what happens? It slows. This performs a beautiful smooth curve in a healthy person. So here it is. Here's a healthy person. These are 6 deep breaths. 1, 2, 3, 4, 5, 6. See? Every time it breathes in, this pulse speeds up and then it slows down, breathing out. So this is a normal, healthy person doing some deep breathing. Here the PNS is intact. Here's a person who has heart disease. The same 6 deep breaths. See how flat the line is. There's absolutely no change, no heart rate variability. Rigid pulse. So this is a defective PNS system causing heart disease. This is a healthy PNS system protecting the person from heart disease. Now, it gets really interesting. See, here's the person, the event. This is where the heart attack happens. See, steadily, an hour or so before the event, the PNS keeps coming down steadily. And in the last 4 minutes, it drops precipitously. And that's when the event happens. After the event, assuming the person survives, it recovers slowly. But in this recovery period, something else bad happens, which we'll talk about later. But this is just to show that this event cannot happen unless this drops. This is during the daytime. Here's what happens in the night. Here's your PNS. See the sudden drop, and this is where the heart attack happens. And then the person recovers if he survives the heart attack. Here you go, you can see. This is where the MI happens. This will wake the person with angina pain. When the PNS gets blocked, like here, guess what happens? See, here's a person with a healthy PNS. Here's a person, this is a heart patient. Look at his PNS compared to a healthy person. Barely functional. Here's the same person during a heart attack. The PNS blockade in heart patients compared to healthy persons. So, lessons to be learned. As long as the PNS heart control remains intact, no acute physical effort, no stress, no exertion due to physical exercise can cause a heart attack, as long as your PNS is intact. When the PNS cannot oppose the SNS, that's when the attack happens. So how does the reduction of the PNS cause a heart attack? In simple terms, a condition called acidosis. When you go to the gym and you work out, hardcore gym people will say they get a burn, right? You know what the burn is? Lactic acid buildup, right? So when the muscle becomes hypoxic and there's an oxygen deficiency, the body switches to an alternative form of fuel, lactic acid. Because the heart is a muscle, the same thing happens in the heart during exertion. Lactic acid builds up in the heart. So let's see what happens. Imbalance in heart metabolism has been studied by putting adrenaline to the person, artificially stimulating the sympathetic nervous system. Okay. When the PNS works well, that excess adrenaline does nothing to the heart. But in the absence of the PNS, you can induce a heart attack. Okay, acidity is dangerous. The buildup of lactic acid is dangerous to the heart muscle. Okay, a total block in PNS activity can make the SNS go out of control. Okay, so that when the lactic acid builds up, and the PNS cannot oppose it, the MI happens. So how does the PNS protect us from excessive lactic acid? The PNS activation helps the body to convert. See, lactic acid in small amounts is an energy source. It's an emergency energy source. But excessive lactic acid, or the inability of the body to dispel the lactic acid buildup, causes lactic acidosis. A well-functioning PNS system can convert the toxic lactic acid into pyruvate, an energy source. This conversion is deficient in heart patients. See, if you're jogging and you build up lactic acid, you can, and your calf muscles cramp up, you can stop, right? But you can't stop the heart when it goes into lactic acidosis. It has to continue working. That's why you need the protection of the PNS in that kind of situation. If it's not there, that's when the MI occurs. So in other words, the heart, when you have an MI, is not suffering from a lack of oxygen due to impeded blood flow. It is suffering from being bathed in lactic acid. So when the heart muscle is bathed in lactic acid and there's no conversion into pyruvate, guess what happens? The heart muscle becomes lame. It goes into spasm, becomes lame, and it's tight. So here's what happens. Brody called it bulge, a paradoxical bulge. This is what happens to the heart muscle in the presence of lactic acid. It bulges, just like diverticulitis and all those things, or an aneurysm. So this is what Brody called the paradoxical bulge. So think of a rubber band. When you stretch it, a wide rubber band. If you overstretch it, things bounce off of it, right? So in this bulge, what happens is fresh blood is not able to enter, and the old blood is expelled, leaving the heart completely deficient of blood. Okay, so a bloodless ischemic area develops due to this. And this has nothing to do, this is due to an acute overexpansion of the heart muscle and has nothing to do with coronary blocks. So what happens in this case of bloodless areas of the heart? Okay, the bloodless areas cause pain and are the basis of attacks of angina. When the PNS blockade is released after several minutes, the scare is not over. Now you have reperfusion injury, right? Because fresh blood is coming into a tense area. So he called it refilling, what happened? He called it refilling trauma. But why is that happening? So, sorry, something's wrong with the slide. Okay. So that area of the heart, which is bloodless, after recovery, the muscle becomes stunned. Right? So what happens is, with every repeated event of this bloodlessness, that part of the heart muscle gets weaker and weaker, until one day the PNS going down and some stressful event will create the acute myocardial infarction. And the whole thing would have happened without the participation of any coronary artery blocks. Okay. Circulation in the coronary arteries plays no causal role in this scenario. But the heart attack happened independent of coronary artery blockage, but it does have an impact on the coronary arteries after the event. So here's what happens. The heart attack has consequences on the arteries. Okay, the blood in the coronary artery leading to the area of the heart congests because of the bloodless thing, and the reperfusion injury causes backward pressure. It congests and often leads to tears in narrow passages in the arteries. These tears lead to thrombosis in about 50% of heart attacks. The larger area of infarction, the larger the area of the infarct, the more this happens. The longer the patient survives during the heart attack, the more frequently thrombosis develop. Notice that the development of the thrombi is after the event. But the process is the same in 50% of heart attacks with thrombosis and in 50% of the heart attacks without thrombosis. During a heart attack, the heart muscles die in an acid, lame, and overextended condition in a bloodless area with or without thrombosis. Roughly 50% are with and 50% are without, proving one thing, that this cannot be the cause of it. Okay, so the sequence of events that leads to a myocardial infarct. Okay, first, the vast majority of cases, the infarct cannot happen unless there's a dip in the PNS system. Okay. Then comes an increase in sympathetic nervous system. PNS goes down, SNS goes up due to emotional breakdown or whatever, stress, physical or emotional stressor. What happens is, when the SNS goes out of control, adrenaline levels go up. Okay, so now the myocardial cells are forced to break down glucose using aerobic glycolysis, similar to what happens in cancer. Okay, aerobic glycolysis. Okay, remember the studies show that the partial oxygen pressure does not change during NMI, as we are told. It remains constant. So keeping that in mind, this glycolysis, because of the exaggerated effect of the SNS, the body switches to glycolysis. So in the presence of glycolysis, guess what happens? The heart is forced to move away from its preferred source of fuel, which is ketones and fatty acids, to an inferior form of energy, glycolysis. And this is what causes the angina. Which is one more reason why heart patients should be fed good fats and not go on a low-fat diet. Okay? So, because of the glycolysis, there's a dramatic increase in lactic acid production. And this happens in 100% of MIs with no coronary artery mechanism required. So the coronary arteries play no role in this, the glycolytic process which leads to lactic acid overproduction. As a result of the increase in lactic acid, the myocardial cells, local acidosis occurs. So that's the start of the process. Now let's look at what happens further. The acidosis causes calcium to be unable to enter the cells, making the cells less able to contract. This inability to contract causes localized edema, dysfunction of the walls of the heart, hypokinesis, which is a hallmark of ischemic disease, and eventually necrosis of the tissue, which we call an MI. The localized tissue edema also alters the hemodynamics of the arteries embedded in that section of the heart, causing shear pressure that ruptures the unstable plaques, which further blocks the artery and worsens the hemodynamics of that part of the heart. So remember, the plaque ruptures after the event, as a cause of the event. Only this explanation answers the following questions. Why plaque ruptures? What their role in the MI process is? What and how they should be addressed. Only this explanation accounts for all the observable phenomena associated with heart disease. The true origin of heart disease could not be more clear. Now, we come to a very interesting observation. In spite of the thrombogenic theory being wrong, some of the drugs that are used to treat acute MIs do actually work, but not for the reasons we are told they work. It's important to understand that. So let's look at it. See, nitrates, which stimulate nitrous oxide production, upregulates the parasympathetic. So their benefit is because they are improving parasympathetic activity, not increasing oxygen. So aspirin and statin drugs stimulate production of acetylcholine and nitrous oxide. So two principal mediators of the parasympathetic nervous system. So their benefit is in improving PNS activity, not blood thinning as is popularly believed to be. Beta blockers are called beta blockers because they block the activity of the sympathetic nervous system. So in the absence of good PNS activity, the beta blocker puts the brakes on SNS, excessive SNS activity. So the risk factors and interventions which are proven work because they help the PNS, not because they're thinning the blood and improving oxygen. So the effect of these drugs on plaque and stenosis is of minor relevance. Far more important is what they do to the parasympathetic activity. So by mistake, they arrived at some workable solutions, which is good for us. So to summarize, the popular thrombogenic theory leaves a lot of inconsistencies and a lot of unanswered questions. Study after study shows that heart attacks do not happen in the absence of oxygen or due to impeded blood flow to the heart muscle, because the collaterals clearly prove that upstream of the block's blood supply is quite sufficient. And the heart is always well perfused. So if that didn't cause the heart attack, what did? It is a dip in the PNS activity that forces the heart to go into glycolysis, that creates excessive lactic acid, and the heart is bathed in lactic acidosis, and that is what leads to the MI. And the recovery from that and the reperfusion injury causes the tears and the lesions in the coronary arteries, which in turn lead to thrombus and plaque buildup and the rupturing of plaques. And some of the drugs which are used do actually benefit the patient, not because they are thinning the blood or improving oxygen flow to the heart, but because they're improving parasympathetic nervous function. As long as the PNS is functioning properly, no amount of stress can cause a heart attack. For a heart attack to happen, the PNS has to fall and the SNS has to rise. So as long as you control, so the whole focus should be away from the coronary arteries and focusing on the heart muscle, preventing lactic acid buildup, keeping your parasympathetic nervous system functioning properly, and allowing the patient to be able to develop methods of keeping a healthy parasympathetic nervous system. So there are many roads that lead to Rome. Okay. So vessel factors explain the development of small percentage of heart attacks. So what I've just told you the PNS control does not explain all heart attacks, but it explains most of them. There's another phenomenon called a broken heart disease, or it's called in Japanese, it's a takotsubo, which is the heart muscle goes into spasm and does not release. Okay, that's known as the broken heart syndrome. These people are emotionally overexcitable. Okay. There are probably other reasons which we still have not found out, such as nutritional deficiencies and stuff like that. But in order for us to be more effective in treating heart disease, we need to remove the blinkers and look past the coronary arteries into the heart muscle itself to improve chances of healing. And so what are the things you can do to improve your PNS functionality? Some simple things, for example, learning to forgive, very important. Having friends and a sense of community, not feeling detached from society. Okay, and in the last few minutes, let's go through a simple exercise. Do not be fooled by its simplicity. This has been tested scientifically. It can, once you get good at it, it will improve your heart rate variability by more than 400 to 500%. So every time you are in a stressful situation, or you feel that you're developing heart disease, or the doctor has told you, increase this exercise every day of your life, and you will be protecting yourself. So what I'd like you to do is just sit back, relax, close your eyes, and we're just going to do 3 steps. Just follow my instructions. It's a very short, quick exercise, and don't be fooled by its simplicity. It will really improve your heart rate variability. And this is the best medicine against heart disease. Close your eyes, relax. So I want you to put, if you're right-handed, your right hand. If you're left-handed, your left hand on the area of your heart, gently. So this is called heart feeling. So feel your heart beating gently. Sorry. Feel your heart beating gently. Now I want you to do what's called heart breathing. Direct your breath into your heart. Direct your breath into your heart. Now, I want you to hold a picture in your mind of something pleasant in your life, like a beautiful sunset or a beautiful flower or a young child running to embrace you or a pet. Something that makes you feel good. And that's the exercise. The more you do it, the better you'll get. And if you want to test it out, go to someone who has a heart rate variability software program and check it out. You will see that in a few seconds, you can bring your HRV into a very healthy pattern, smooth curves. In acute cases, we use what are known as cardiac glycosides. One of them would be a homeopathic remedy called Strophanthus. Okay, and in the subway, the underground subway systems of New York City, I have helped many people in the middle of an infarct before the paramedics could arrive. We would have lost them, but Strophanthus has saved their lives. So I always carry a bottle of Strophanthus. Okay, you do that, and most of the cases you can help. Let's finish and then we'll talk. Okay, so the whole key is to control the parasympathetic nervous system and don't let the sympathetic nervous system run away. Okay, thank you very much.
Do we have any questions for Dr.?
Is it true that using certain exercise, we can engineer the heart rate variability, meaning to increase it so we can have such an ideal PNS? Is that possible?
I'm sorry, say that again?
Okay. Is it true that using certain exercise techniques such as hot sauna and cold thermogenesis, we can increase the heart rate variability, so meaning that we can also increase the PNS? What's your comment on that?
Okay, so let me ask a question. What do you think increases PNS activity in terms of exercise and what reduces PNS activity? Can you tell me?
Yeah. By doing some kind of exercise, meaning that we can increase our endorphin.
Yeah.
Definitely. And it will make our state of mind becoming more relaxed. And definitely I think that it will also improve our parasympathetic nervous system.
Yeah. So what kind of exercise?
Such as hot sauna and cold thermogenesis therapy.
Very good. So which one increases the PNS and which one decreases the PNS? Keep in mind, when you breathe in, your pulse rate accelerates. When you breathe out, it slows down.
I think hot sauna will increase HRV, and cold thermogenesis definitely will decrease the HRV. But if we can do it simultaneously, I mean not simultaneously, but after hot sauna and then just do the cold thermogenesis a couple of times, then we can treat or exercise our heart muscle as well.
See, it's actually counterintuitive. Warm weather actually improves PNS activity.
That's right.
Cold weather diminishes PNS activity.
That's right.
Okay, a far easier way is to do deep breathing. You will notice most heart patients are not able to sustain deep breathing. It makes them uncomfortable. So one of the ways to practice strengthening your PNS is to do deep breathing exercises like yoga or something like that. Does that answer your question?
Yeah, thank you.
Dr. Suresh.
Thank you, Doctor.
Yeah. Okay. Which will be much better to evaluate the cardiac functions and conditions, heart rate variability or the ECG?
I'm sorry, repeat your question. Which is better, you're saying?
Yeah, which will be better way to investigate and find out about our patients? ECG, stress test, or heart rate variability test?
I would prefer the heart rate variability for two reasons. One is it's a far better predictive test.
Okay.
Okay, long before something bad is going to happen, you can tell, because you'll see pretty much a flat line. And by improving the heart rate variability, you're actually helping the patient to head off an impending heart attack.
Okay.
So if you have a patient who's suspected of having heart disease or who has a history of heart disease, one of the fastest ways of getting him out of danger is to improve the heart rate variability.
Just for the benefit of most of the doctors here, I think they would not know what kind of instrument is a heart rate variable. Can you just explain so that they can know where to get that and how you could guide them?
There are many different kinds of heart rate variability equipment available. The simplest one is a software-based program where it's like you have like a pulse oximeter which you wear on your finger, and it's connected to your computer, and it plots your heart rate variability. And it's a good way of seeing whether you're improving or not by doing this exercise. That's why I'm telling you the exercise is so important, because it's very simple, but it really helps you to become an expert in generating good heart rate variability rhythms. I'm sorry, you asked a question. I'm sorry, I couldn't hear you. Strophanthus. There are different types of strophanthus. The one that works, it's a whole deep subject which we didn't have time to get into. Cardiac glycosides is a whole subject which can be used and which we do use in our clinic to treat heart patients. But the simplest way would be to get the homeopathic version of this thing called Strophanthus gratis, Gratus. Strophanthus gratis. It's available. One of the best companies is a German company called Sanum, S-A-N-U-M. And you can get their Strophanthus thing. It comes in tablets or it comes in a liquid form. The tablets are easier to carry, so we make most of our heart patients carry those things. So there are people in the middle of an MI. You make them pop it every half an hour, and you see the MI goes away.
Sorry. Thanks, Dr. Suresh. Is there such thing as an excess heart rate variability? Is there a threshold or certain limit?
Excess heart rate variability?
Yeah.
Yes, it can be. It can be.
So where is the fine line?
It's almost impossible to reach that threshold. So I wouldn't worry about it. There are people who are like expert meditators who can actually create that condition, but they also can uncreate it, so it's not really a problem for them. But it's very difficult for a normal person to get to that point where your HRV is so wide that it's going to be harmful for you. There are certain diseases, congenital heart diseases that can cause that, but that's a whole different topic.
All right. Okay.
That's it? Okay, thank you very much.
Thank you, Dr. Shottam. Okay, can we announce may we ask Dr. Homer Lim and Dr. Matzia for the token of appreciation, please?
Dr. Nelson is ready.
I think there's going to be an announcement
Yeah, I'll announce it. Yeah. After this. Yeah.
Where is he?
Here. Okay. All right, thank you again. Okay, before we proceed, a very quick one, a 2-minute announcement by Mr. To.